Good evening. I'm Jack Needleman. I'm professor and chair of the Department of Health Policy and Management at the Fielding School, one of the homes for the Health Forum, and I'm delighted to welcome you to this first forum of the calendar year, the first full year in which Paul Torrens' name has been tightly attached to the forum. It's going to be a great year for the forum. The planning group has been working on extraordinary things, so I want to invite you to keep coming back, or at least to stream it if you can't physically get to campus. The first session today is a terrific one. I'll talk about that in a moment and introduce the person who's going to be moderating it. But before I begin, I just want to acknowledge, as we enter into the new year, it's a transition period, one of the losses that the school has had in terms of a good close friend. Indeed, not just a loss for the school, but for Los Angeles and the state. Gail Margulis, who was a good friend of the school, passed away this September following a brief illness. Most recently, from 2004 until her death, she served as vice chair president for government and public policy at Children's Hospital in Los Angeles. And before CHLA, she had worked in a number of positions, including serving as chief counsel at Daniel Freeman Hospital and as president of one of the leading health law firms in the community, which indeed she had helped found. While she was at Children's, Gray Davis, the governor, appointed her as deputy director of the California Department of Health Services, and Gail was also CEO of the Scleroderma Research Foundation in Santa Barbara. So an amazing range of experience in healthcare, the common theme of which making a difference in children's lives, making a difference in people's lives. And for that, we need to acknowledge her and acknowledge her passing and her loss. And I think all feel compelled to take on some of the charges and some of the load she was lifting in trying to improve health and healthcare in Los Angeles. This evening's session is really about the end of life, but making sure the end of life is as good as it can be and as good as it should be, and thinking about what that means in some very real and serious ways. It's a topic that has emerged as a critical issue in healthcare policy in the state, involving issues of general ethical and moral considerations about the roles of physicians, about respect for and assuring true patient autonomy in healthcare decision-making, and in the challenges and fears that patients have about being appropriately and well cared for at the end of life. We've got an incredible panel, and I'm going to let the moderator for the session introduce the panel. But I want to speak briefly about the moderator himself, Neil Wenger, who is exactly the right person to be leading this session. Neil's professor of medicine in the Division of General Internal Medicine at UCLA and a consulting researcher at RAND. He's director of the UCLA Healthcare Ethics Center and chair of the Ethics Committee at the UCLA Medical Center. He's also director of the Nurser Primary Care Research Fellowship in the UCLA Division of General Internal Medicine, a program that has sent us many of our best students. And he is an active general internist, so he speaks both from his clinical experience as well as his research experience. And he's carried out research and empirical study of clinical ethics, care of, and decision-making for older patients, the quality of health care. He received his MPH from the Fielding School and is going to be, and I'm really pleased to have him leading this session. Neil?
Thanks so much, Dr. Needleman. It's really an honor to be able to moderate a session for the Paul Torrens Forum. I learned a lot from Dr. Torrens getting my NPH, and am quite appreciative of that. Tonight's, it's really nice to see such a big group to consider tonight's topic, which is the aid in dying law. This is the chance that a person has at the last stages of illness to request a medication to hasten death. We will learn from Oregon's experience over the past 18 years, and perhaps that can help inform California. But there are still many questions that remain for the implementation here in this state, in part because this state is different, and in part because there's still much more to learn. How does this fit into the armamentarium of things that physicians should do? How do we protect vulnerable people, or do we need to be protecting people or providing access? How do we monitor what is actually going on, and how do we make this fit into an understanding of all of the options that people have toward the end of life? How do we train clinicians to do this right? We have a wonderful panel tonight that is capable of discussing these issues, and I'd like to briefly introduce them. First, Linda Ganzini is joining us. She is the professor of psychiatry and medicine at Oregon Health and Science University, and she directs the Geropsychiatry Fellowship Program there. She also is associate director at the VA of their Center for Innovation. She has published more than 40 papers and is the lead researcher about physician-assisted death, I think, in the world today. And many of you have probably read her papers in the New England Journal and JAMA and several other places. Our second speaker will be Dr. Sunita Puri, who is the lead physician for palliative medicine and supportive care at the Keck Hospital and Norris Cancer Center at USC. She did medical school and internal medicine at UCSF and a fellowship in hospice and palliative medicine at Stanford. She's co-chair of the Ethics Resource Committee at Keck and Norris and teaches ethics in the medical school there. Many of you may have seen her article in the New York Times just at the beginning of the End-of-Life Option Act implementation here. And she's written in JAMA and JAMA Journal of Medicine and a number of other journals. The third speaker will be Alex Capron, quite well known here in Los Angeles. He's university professor at USC and the Scott Bryce Chair in Healthcare Law, Policy and Ethics at the Gould School of Law. He serves as Vice Dean of the Faculty in Academic Affairs, and he's Professor of Law and Medicine at the Keck School. From 2002 to 2006, served as the first Director of Ethics, Trade, Human Rights, and Health Law at the World Health Organization in Geneva. And between 79 and 83, he was the Director of the President's Commission for the Study of Ethical Problems in Medicine and Biomedical and Behavioral Research. He will bring us thoughts that many of us probably, even those of us who have been thinking a lot about the End-of-Life Option Act, probably haven't considered. So with that, I will very briefly present a little bit about the background of the Act. I'm sure many of you are quite familiar, but want to make sure that when our speakers are able to present, it is with everyone having the same understanding. How do I bring that up? Perfect. Whoops, what did I do? How about that? Okay, so the Act became effective June 9th. What it says is that a capable adult with a terminal disease gets to request a drug for aid in dying. One has to be a resident of California. It's voluntary. It's not suicide as defined by the law, so there's no effect upon life insurance. Health insurance can't communicate about the aid in dying law unless they're asked. There's immunity for people that are present when the patient self-administers the aid in dying drug, and fraudulent requests and coercions are a felony. The physician must submit standardized forms to the California Department of Public Health, and there are actually quite a few of them that need to be submitted at exactly the right time. And then it's the CDPH's responsibility to produce an annual review and a statistical report. The law sunsets January 1st, 2026. It's quite important to notice that this aid in dying is the process by which a capable terminally ill patient voluntarily self-ingests a prescribed medication. We need to distinguish this from any sort of withdrawal or withholding of life-sustaining treatment accepting death, which we do routinely according to patients' preferences and prognosis in hospitals across Los Angeles every day. It's to distinguish it from palliative end-of-life care, which it is not, and certainly not euthanasia, lethal injection, or mercy killing. Who's eligible? An 18-year-old or older California resident who has a terminal illness, which is defined in the law as an incurable and irreversible disease that within the reasonable medical judgment of the attending and consultant physicians will result in death within 6 months. The patient has to have the capacity to make the aid in dying decision and to be able to self-administer the aid in dying drug. Very briefly, the steps to prescribe it are: 1, the patient makes an aid in dying request and a second oral request 15 or more days later, and also turns in a written request that's specified according to the state. The attending physician evaluates if the patient's qualified and the patient's reasons for the request. The physician documents the request and explains the steps and refers to an independent consulting physician. The attending physician then ensures that the patient is making an informed decision. The patient, if they have a mental disorder, is referred by the attending physician to a mental health specialist. The attending then meets with the patient alone to assess for coercion. An interpreter could be present. The attending physician then counsels the patient about the handling, the ingesting, and the writing and the use of the drugs, and writes the prescription. The patient actually signs a consent for the prescription to be sent to the pharmacy. The pharmacist, who also must voluntarily participate, then dispenses the medication and educates the patient. Those are the steps. That's the basis of the law, and now we can begin to hear much more in depth. So I invite Dr. Ganzini to come teach us about Oregon's experience. There we go.
Great. Where's my? That's it. Okay. Thank you so much, and thank you for inviting me down. I arrived yesterday afternoon, and I've given a couple of talks and spent some time with the Ethics Center, and I'm very impressed with the careful and thoughtful approach being taken to implementation of aid in dying. So Oregon's Death with Dignity Act was passed by popular by ballot measure in 1994, and after legal challenges implemented in 1997. And during that time, I and my colleagues have performed a series of studies and surveys in patients and family members and healthcare providers to understand about their views and experiences around the law. So one of the studies we first did was a survey of 4,000 eligible physicians who would be eligible to prescribe. In 2000, we did everybody because we just didn't have a clue what was going on. There was no real way to do a power calculation. And at that point, 5% of physicians had received a request for a lethal prescription. One of the arguments around physician-assisted death was that we should consider hospice as an alternative. But in fact, the majority of patients we were finding were enrolled in hospice at the time they made a request or received a lethal prescription, 91%. And so we did a survey of hospice nurses and social workers in 2001. And at that point, almost a third had cared for a client who had made a lethal prescription. We also did a study then in 2005, 2006 of patients who explicitly had requested physician aid in dying to understand their reasons for making the request. Why do we care why patients make these requests? The reasoning. And it's because even if one supports the law, we hope and aspire to this being an option of last resort. And so we're looking for other potentially treatable or addressable conditions so that the patient would potentially make an alternate choice. So what do we know about Oregon's experience? Well, there have been almost 1,000 deaths by physician-assisted death between 1998 and 2015. We had worried when we were debating the law that people would make this choice because they were disenfranchised, vulnerable, unable to access care. And what we found was just the opposite. 97% of deaths in Oregon from physician-assisted death have been in people who are white. They're equally divided between men and women. 91% are hospice enrolled. Sunita will talk more about hospice, but it is really the Cadillac of comprehensive end-of-life care. Most die at home. And in a state where 15% of people have lacked health insurance, only 1 to 2% of people who die of aid in dying lack health insurance. I don't know of a situation or condition in medicine that we've worried so much about for which the risk factors have been being wealthy, white, and insured. In addition, people who make this choice are 8 times more likely to have a bachelor's degree. In all of our studies, we have a simple 0 to 10 scale that asks people the importance of religion in their life. Not surprising, religious belief is protective against making this choice. But I think what's more interesting is that no matter which group we ask, in terms of healthcare providers, they have a mean score of between 6 and 7. But people who choose physician-assisted death have a mean score on this scale of 2. They are the singularly most unreligious group of people that I've ever interacted with. It's simply not important in their life. I mentioned yesterday we also used to have a 0 to 10 spirituality score, but in fact, everybody in Oregon scores on an average of 9 on this. And so, showing no variation, we ultimately deleted that measure. In the discussion of legalization, one of the major arguments was around the role of symptom management. The concern that patients would make this choice because they had untreated pain or untreated symptoms, and the argument that we are getting better at treating pain and that should be our focus, versus the argument of the other side who said not all pain could be treated. So in our study of requesting patients, we had them mark about 20 different reasons why they may make this choice, with 1 not important and 5 as important. And in terms of their current symptomatology at the time they made a request, the mean score in all of these was 1. These are surprisingly unsymptomatic patients. Now, one of the things is that there's probably only about 30 to 40% of people who we had requested participation participated. So sicker, more symptomatic people maybe didn't participate. But in fact, in our study of hospice nurses, they consistently said that people who made this request had fewer symptoms before their death than most other hospice patients. But interestingly, if you look about patients' worries about the future, this is a key issue. It's not the symptoms they have, it's the symptoms they're worried about in the future that are motivating them to make this request. As a psychiatrist, I particularly worried about the role of depressive disorders. We know that depression is the largest risk factor for suicide in the country, that depression is treatable, and when treated, people will be no longer suicidal. Interestingly, among our requesting patients study, about a quarter of the patients had a major depressive disorder, which is about the rate of major depression in terminally ill patients. So there's not a clear, is it attributable risk? Did I say that? Social workers, clinical social workers who have a great deal of experience with mental disorders in patients at the end of life, rated on this 1 to 5 scale depression as among the least important reasons patients were making these requests. So that was reassuring. Though among the 15 in the patient study, 3 of those patients did access lethal prescriptions very soon after participating and died very quickly without ever receiving a mental health evaluation. So this is one of the areas of the law that is not working as well as we had hoped. So if it's not depression and it's not pain and it's not the care that they are giving, why do people make these requests? This is really about people's wanting to be self-sufficient, in control, and independent. And in fact, if you look at the future state, I have to stay here, the future state of control, the median score on the 1 to 5 scale was a 5, and the interquartile range was 4 to 5. It is almost unheard of to have a patient make this request and not have the major reason being about their control. In addition to our surveys and many of these studies, we did qualitative interviews with physicians. We interviewed 35 physicians across the state. And I think this is where we get a better idea about the role of control. One physician said about a patient, but these were individuals who wanted to control their lives, and it was mostly a control issue. And they sort of stated it at the get-go. It had nothing to do with the care they were getting. And they would return to it, and you could say, well, you know, we're doing all we can. We're making this commitment to you, and we're trying to take care of you. But they sort of fixated on ending their life from the get-go. Another physician about a different patient. He was a very stable patient. He wasn't someone who was in a lot of pain physically, and he was the captain of his own boat. And that's how he had been his entire life, and he wanted to die a certain way, and he did it, and I think he just ultimately wanted to have control. A story, again, from a different physician. When I saw her, she was very, very weak and very dehydrated. And again, I told her, gee, you're within a couple of days of losing consciousness just from dehydration. And we could make sure you slept and did not suffer, and it would be a short time. She had made a decision, had the 14-day wait, and had 4 more days before the medicine could be prescribed. And I told her I didn't think she'd be able to do that unless she could solve the nausea and the dehydration, that she would last 4 days consciously to take the medication. And she struggled into a sitting position and asked her husband to get a glass of water, and she says, I'll get the fluids down somehow. See, that's the paradox, where you learn that lesson about the control issue, that she actually reversed the natural process to prolong her suffering, if you will, in order to be to control and to push the button herself. In addition, these are very highly independent and focused on self-sufficiency. Just an example, he was a typical rural resident in the sense he was tough, macho, in control of himself and everything else kind of fellow. So in summary, many of the findings have been counterintuitive and unexpected. That this is really not about care people are getting. If in fact, I would say there's an unusual disparity so that people without resources may want this option but appear not to be accessing it. And the other factors that are associated are this low measures of religiousness, strong need for control, prizing self-sufficiency, not wanting to be dependent on others, struggling to find meaning in the dying process, fear of worsening symptoms, and lack of denial about the future. Thank you.
Thank you, Dr. Ganzini. I bet that was surprising to some. Now, Dr. Sunita Puri is going to put this in the context for us of palliative care and end-of-life care.
Thank you for having me here today. As a little bit of background, what I'm hoping to do is to provide a palliative medicine perspective on this very nuanced debate, particularly from my experience writing the End of Life Option Act policy at the University of Southern California. I think that the passage of this law says a lot about the landscape of end-of-life care generally in our country, not just in California, and provides a really good opportunity to talk about all of the options that are available for patients, not who are just at the end of their lives, but who have an advanced and symptomatic illness. Hospice and palliative medicine are both terms that have been relatively misunderstood, both by the public but also by practitioners within medicine and nursing. And just a quick show of hands, how many people have heard the term palliative medicine and wondered what that meant? Good, I appreciate the honesty. My parents are here and they raised their hands too, so that says something. And there is really variable, not only understanding of these services, but also variable availability and quality of these services. Generally, and I'm going to talk about what palliative medicine is and what hospice is in just a second, but I do want to emphasize that these are services that are generally introduced fairly late into a patient's experience with advanced illness, even though they can do quite a bit of benefit. For example, the median length of stay on hospice was 18.5 days in 2013, when anybody with a life expectancy of 6 months or less in this country is actually eligible for hospice. And 34.5% of patients on hospice were on hospice for less than 7 days, which says a lot about how we approach the care of dying patients generally in our country. So the End of Life Option Act in California was passed within this context. And I see it as an opportunity to discuss and correct deficiencies in the option of care available for patients who are struggling with an advanced illness. And I asked myself as I was starting to write the policy, in what way could improved availability and quality of palliative medicine and hospice impact the cultural context in which this End of Life Option Act has passed? So you think about a palliative medicine consult, and a lot of people aren't sure what that means. What palliative medicine is an interdisciplinary team approach to the care of a patient and the family when there's an advanced illness affecting someone. Interdisciplinary means that there's a physician, a nurse, a social worker, and a chaplain to address all the various domains of suffering for the patient and the family that come with having a serious diagnosis. In terms of symptoms, we're experts at managing pain, nausea, vomiting, shortness of breath, anxiety, and depression, amongst others, that are sometimes due to the illness, but are sometimes also due to the treatment of the illness. And we also help facilitate advanced communication around goals of therapy, as well as provide emotional and spiritual support, because we recognize that suffering has many domains beyond the purely physical, and one of them is certainly the existential. We generally encourage people to consult earlier in the disease course, but because we have a culture of medicine that's very aggressive in this country, generally more is done before a pause is taken to see where the direction of care is going. It is worth noting that palliative medicine is not widely available. It's often in academic centers as opposed to community centers, and it's mostly in hospital settings as opposed to outpatient clinics or home-based palliative care. So there's a number of ways in which palliative medicine as an end-of-life option or option for care of patients with advanced illness has not achieved the penetration it should. I think of hospice really in this way, which is that it is a type of palliative medicine for patients in the last 6 months of life within the best judgment of 2 doctors. Hospice is generally provided at home as opposed to in a facility, with the exception of skilled nursing facilities where some hospice is provided. But people often hear hospice and they think of a beautiful facility, and that's just not the case in our country. You have the same interdisciplinary team looking to meet the same needs, physical, emotional, and spiritual suffering of the patient and the family, but it's generally done in the home setting. Patients can elect to stop hospice if they desire if they improve and are able to go back on, for example, a clinical trial. But in general, hospice and palliative are equated, unfortunately, with giving up and doing nothing, which I really want to emphasize is not the nature of these services. And how we frame these conversations, including conversations about the End of Life Options Act, is critically important to how we guide our families and patients to making the decisions they will make. This is my little diagram of hospice as a type of palliative medicine. So the challenges facing these other options that have been in existence, hospice since 1982 when the Medicare hospice benefit was passed by Ronald Reagan, and palliative medicine more recently, really from the 1990s on, there are a number of issues with lack of access and variable quality of the services. Home-based palliative medicine is often really wonderful for patients who, for example, are early on in their disease course getting chemotherapy, but are homebound and need a team to come in and help with symptoms and, again, address the many domains of their experience, but home palliative is exceedingly rare. Hospice availability and quality can also differ greatly, especially geographically. At USC, we cover a really pretty wide catchment range of where patients come from, and there are times where it's hard to find a hospice agency for patients in remote areas. There are varying levels of physician comfort with discussing these options, in part because, just like many of our audience members, some of my colleagues have not really known what palliative medicine is. And that's not their fault. It's just a result of where we place our emphasis in medical education. And both fields, unfortunately, have at times been misconstrued as physician aid in dying. They're thought of as synonymous. So the passage of this law offers an opportunity to clarify all the options that are available and how we can talk about them in a meaningful way. And I think it's an opportunity also to improve all options available to patients with advanced illness. What I thought would be helpful to share with you is the result of the survey that I sent out to our physicians at Keck and Norris at USC, really trying to get a sense of their own attitudes, given that we operate in a context in general in medicine where hospice and palliative medicine are not very well understood, and approaching care of patients who are nearing the end of their life can be difficult. So now we have this act passed. What's the best and most compassionate way to get the feelings and experience of the colleagues that I have there, but also do what's right for our patients or make the right option available for our patients? So the couple of things that we added in, again in the vein of improving access to all possible care that patients can have at this stage, was we wrote in a mandatory palliative medicine consult for any patient at Keck and Norris looking to pursue the End of Life Option Act so that they aren't deprived of an opportunity to have any symptoms that they have that aren't optimally treated addressed properly. And by symptoms, again, not just physical, but existential, spiritual, and emotional as well. We also required the use of a navigator who's a social worker who does an initial psychosocial screen and follows the patient and family throughout the process of going through getting the forms done, seeing the attending and consulting physicians and a mental health specialist if necessary, again, to provide support and constant contact about how symptoms or experiences are changing. And we also required the completion of a POLST form and an advance directive, so that, again, we use this law as an opportunity, as a vehicle to have people get good advanced care planning done. So just to share some of the feelings of the providers, I should note that of about 700 practitioners at our center, only 170 completed the survey, so it's about a 24% completion rate. But as a medical provider, do you support the End of Life Option Act? So 62% from multiple disciplines and many different levels of training said yes. Only 18% said no, and about 20% were unsure. Would you feel comfortable serving as the attending physician, who's the one who would write the prescription? So 49% said no. Interesting, because even though a good percentage supported the act in theory, writing the prescription was we got a different answer. 30% said yes, and 21%, again, about 21% unsure. Would you feel comfortable transferring care to a colleague who was agreeable to take on the attending role? Yes, 77%. Good. Unsure has dropped to 11%, and 12% say no. Would you feel comfortable serving as the consulting physician? 44% said yes, 35% said no, and again, that 21% really unsure. What would make you feel more comfortable about this act? So the ability for a physician to opt out, which of course is protected, and the mandatory palliative care consult was the second highest, as well as formal training on the program and the medications to be used. Some of the verbal feedback we got in focus groups was really that people weren't sure what they were prescribing and what the effects would be and whether it might actually harm someone. So really wanting to be informed was part of their own ethical reasoning about whether or not to participate. And I thought I'd conclude with the part of a statement from the American Academy of Hospice and Palliative Medicine, which takes a position of studied neutrality on the subject of whether physician aid in dying should be legally permitted or prohibited. And they do say efforts to augment patients' psychosocial and spiritual resources so they are better able to manage their suffering may make palliative treatments of physical symptoms more effective and may make these circumstances rarer. Nonetheless, some patients will continue to desire PAD. So I see this as recognizing that well-intentioned, highly ethical people stand on both sides of this debate, and what can we do about how the passage of this law, what is the commentary about all options that are available or inaccessible to people with advanced disease. Thank you.
Thank you so much. And now we get to listen to Dr. Capron, who I believe will talk to us without PowerPoint. Imagine that.
Thank you, Neil. Neil said at the beginning of the introductions that I would present a lot of new information for thought, and I'm going to say that I'm not going to do that. I'm going to try to present some things that I suspect you are all familiar with, but to put them in a different context and to comment about what we can possibly learn from looking at them, both in a historical way and looking toward the future and questions about where this law will be going. I want to take us back basically 40 years to April of 1975, when a 21-year-old woman named Karen Ann Quinlan went to a party, took some pills, we're never sure exactly what happened, had some drinks, and was found unresponsive after she got home, after she was taken home, not feeling well. And of course, you know what happened over time. She did not recover. She was in what came to be called the persistent vegetative state. Her family, after about 4 months, came to the position of saying that they wanted to have the ventilator that was supporting her breathing removed, and the physicians were unwilling to do so. And the reasons the physicians gave is relevant to what we're thinking about today, because they said that the Morris County, New Jersey prosecutors had said that the removal of the ventilators would be homicide, criminal homicide, and that they would be prosecuted. And of course, they weren't interested in doing that for that reason. So the Quinlans went to court, and about a year later, the 31st of March of 1976, the New Jersey Supreme Court granted their appeal, saying that the right of privacy, which had been recognized in the context of Roe versus Wade, was broad enough to encompass their request to remove Karen's life support. Now, it was said by some of the neurologists, Fred Plum and others who examined her, that they were not convinced that she wasn't going to be able to breathe on her own, and indeed she was able. What made the story particularly poignant is that she lived for another decade until 1985, and when Joe Quinlan was asked about his willingness to withdraw the respirator and was asked would he therefore withdraw the feeding tube, he said, "Oh no, that's her nourishment." And he wouldn't think of withdrawing the feeding tube. Now, in the process, the New Jersey Supreme Court launched something that has now become a commonplace part of all the hospitals, which is hospital ethics committees, because the ethics committee, it was said, would have to approve the decision. That was, however, we should remember, a judicial ruling in that case, and as Neil already mentioned, is not something which is characteristic of most withdrawals these days. Now, that case raised for the public and for medicine and for the organs of the state, both the courts and the legislatures, a number of concepts. One of the concepts was, well, what is the professional position? What's the professional tradition on an issue like this? Is there a difference between withholding care and withdrawing care? What is a terminal illness? And what is extraordinary care? That last point was a matter of a great deal of confusion at the time because many people thought of it in terms of the complexity of the care and so forth. But it was clear this was actually a concept borrowed from Catholic moral thinking because the Quinlans themselves were Catholic and it had come up in the court in their case that it really meant it's something that is disproportionate. And the thought was that certain kinds of care, given the outcome that's possible, are disproportionate. Yet within 15 years, by 1990, and the decision of the United States Supreme Court in the Cruzan decision, which recognized the previously expressed wishes of Nancy Cruzan not to be tube-fed and kept alive if that circumstance would ever arrive, was also had to be legally respected. And so an individual who has lost power to make decisions could have that former wish acted on. In other words, the law came to rest on the ethical principle of respect for persons, the authority of the individual over his or her own body, which includes the right to have possibly effective care withdrawn or withheld, and really said that there was no difference between the two of them, even if doing so would lead to death. It seems to me that at this point, in the late 80s, early 90s, we see the topic of end-of-life care from a legal perspective, and I think from a clinical perspective, branch into four separate branches. The first was the development of extensive means to allow people, while competent, to control the care that will be given to their body when they are no longer able to express their wishes, and that had already existed as an idea with the living will going back to the 1960s. But the living will on its face was not a legally binding document. And so over time here in California, shortly after the Quinlan case, the adoption of our Natural Death Act, which revealed in the legal language a great deal of ambivalence over what should be going on and when. But then that presidential commission that Neil mentioned that I directed was the origin of the idea of the durable power of attorney for health care, focusing not on choosing the moment and circumstances that one would want to die, but rather choosing the person who one would feel comfortable making that choice. And over time, that whole idea of an advance directive got federal imprimatur through the Patient Self-Determination Act, really giving recognition to whatever law a particular state had adopted and saying that hospitals and other care settings had to make sure that patients were aware of those rights. Now, all of that may seem very obvious, but in fact, there remains a good deal of controversy at a philosophical level about why it is that if one thinks of it as we often express it, that there has been a real change in the person once they've become severely compromised or unconscious in a permanent way. Why another person, their former self, is the one who makes those choices. And there is a lively debate about whether the choice should be made based upon whatever I write down on a piece of paper today, or what seems to be my interest at some future time. Now, the second stream really arose in the 1990s as conflicts started to come up in which physicians were not, as they had been, the impediments to discontinuing care, but now were the ones urging that the care be discontinued. And we associate this with the idea of futile care. Doctors and nurses saying, it's futile, why do we have to go on? Very often in circumstances where it wasn't the patient who was speaking, but rather a family member on behalf of the patient. And we now have, in many states, we have here in California, a law which doesn't put it that way, but talks about non-beneficial care. Now, that term may seem slightly preferable, but neither futile nor non-beneficial has an obvious meaning. And it certainly is a subjective term. What is beneficial? What will not lead to a worthwhile result? So that's the second stream. The third stream is the rise of palliative medicine and a practitioner's role in managing the dying process. As you heard, that really began separately from hospitals in hospices, which were identified with a name that goes back to an earlier era, and the original interest in this came from people outside the medical system, but as Dr. Puri has just told us, is now a combination of what happens with palliative care in the hospital and at-home hospice or other non-institutional hospice. But it's important to notice that as part of that, doctors practicing this kind of care have taken further steps and have gotten to the point of comfort with things such as inducing a coma in a patient whose level of comfort cannot be maintained without that. And so this is a form of terminal sedation, or for that matter, managing the care of a person after food and fluids not artificially provided, but provided by mouth, have been stopped because it doesn't seem as though the patient is deriving benefit from continued life. Notably, outside of the occasional litigation, as Neil mentioned, these kinds of things now all go on routinely and non-controversially. Ethics committees do not look at most of these cases. They look at the few cases where things have broken down, and often when there are misunderstandings, sometimes induced by different physicians telling the patient different things, as physicians often talk about their own organ. Oh, the kidneys are fine. Yes, everything's fine. The patient's about to die of cancer, but the kidneys are fine. Well, that's what the family hears is the patient is fine. It doesn't mean, however, that there is anything other than a great deal of discomfort with all of this. Now, I want to relate those three different streams to what has happened with the movement for euthanasia and physician-assisted death. And what I want to do is to bring to your attention the ways in which that is very different from these other things. And I'll go through these quickly. First, it is situated in a criminal law context, not only as an exception to the prohibition on assisting suicide, but by creating a whole bunch of other crimes. Secondly, it is burdened with a lot of detailed paperwork that doesn't apply to any of those other streams in death and dying. And if we want to know why the percentage in Dr. Puri's study, and I know we have a similar sort of percentage from what's happened for ongoing work that's being led here at UCLA, I would say let's look at the way we've singled this out and burdened it with a lot of paperwork. It may be very suitable paperwork, but it may also help to explain why a lot of physicians say this is different and I'm not comfortable with it. Another thing is the action versus inaction distinction, which we've totally abandoned in other areas of dying, is very active here. And let me just give you an example. Suppose we have a patient who is simply too weak to take the pills that have been prescribed. Cannot do that physically. Can't pick up the pills, can't pick up the glass of water, just physically can't do it. For her physician to do it for her, I believe under the statute is illegal. It's euthanasia. It's not allowed. And yet for many people looking at the situation, I think would find it puzzling. But that's the difference between action and inaction. The physician is writing a prescription, but the patient is doing the action, and we can go back and discuss how that became the distinction after the defeat of the California initiative back in the early 90s. Then there's the requirement for current capacity. There are no advance directives. The thing that is the cardinal thing about other forms of dying is not allowed. You have to be currently capable. And yet, we know that from the public opinion polls and from some of the examples that were very prominent in some of the votes to allow this to happen, the notion of getting a degenerative disease, a neurological degenerative disease, here we are in the neuroscience research building, is one of the most frightening things of all. And it's the kind of thing people say, I want to have that right. I don't want to go on. You don't have that right. If your disease will rob you of the ability to make choices, you're not covered by the law. And then finally, there's the ambiguity on the basis. Now, in the other areas, as I've said, it is clear that self-choice is what is involved. The respect for the person's control over their life, their own decision of whether their life is worth preserving and living. And in some countries, that is the view, but here in California, it's not the view. You have to have a terminal illness. It's not enough to say, my circumstances are not ones that I want to continue with. There's the imminence or unavoidability of death, and that is different from all the circumstances involving prolonging treatment. You don't have to be imminently dying to be able to say, I don't want further treatment, I don't want cancer chemotherapy. Well, without it, you'll be dead. You know, but we might be able to save you. I don't want it. No one says, oh no, you're not permitted to do that, because with it, you could live on a long time. It's interesting under the law, which talks about incurable and irreversible, whether anyone is going to be concerned that something isn't necessarily incurable if enough efforts were made. And finally, as was mentioned by Dr. Ganzini, the existence of pain is often talked about in public discourse on this. The notion that no one should suffer irremediable pain. The governor said that when he signed the law. We now had a law so no one would have to suffer pain, a painful death. But in fact, painful death is not required, and painful death is not the reason for the use of the statute. It's all about desire to be in control and to have a certain end of life as you had control during your life. So looking to the future, what are the implications of the normalization of this practice? I think we have to be aware of the risk of a pendulum overswing. Almost every change in the law is dealing with a problem over here, and we get the pendulum swinging, but it doesn't come to a stop in the middle. From the presumption of doctors never ending life by aiding a patient directly to die, and other people only doing so if they have a very strong reason for doing so, we now will have, in effect, the opposite presumption. You would need a very strong reason as a physician if you have the capability and a patient who qualifies. Why aren't you helping them? The law allows you to do it. Why aren't you doing it? We will also remove, the question is, will we remove the requirement for acting alone? I think that this is one point on which there may be a legal challenge. Go back to my example. Why is the person who is mentally capable, but physically incapable of lifting her hand to her mouth or holding a glass of water, Why should she be denied the same kind of control over her dying process? Why do we exclude that level of aiding on the ground that it is euthanasia rather than physician-aided death? Will we remove the requirement for certainty and the imminence of death? Why require imminence? What's so special about 6 months? Will we remove the requirement for current capacity? As I say, all across the other areas, the notion of making choices that will bind your future self are accepted. And finally, what would happen, and this is just a thought experiment I want to leave you with, what would happen if we faced someone who said, I want to have physician-aided death so that I can be an organ donor? If the method will not damage my organs, I want to be wheeled into the operating room, given the pill, I'll put it in my own mouth, I'll take the water, and then as soon as you can determine that death has occurred, which you ought to be able to do pretty quickly and pretty certainly, remove my organs. Does that seem bothersome to anyone? I'll leave it with that and maybe we can discuss. You want us up here?
Let me invite the speakers to come forward. Now it's the time for questions for our panelists. I want to just point out that this session came out of a project in the Fielding School of Public Health that has been directed by Cindy Kane with guidance and some funding from Tom Weinberger. This topic can be emotional for many, and I ask that these are respectful questions of our panelists rather than statements about people's personal opinions. And with that, we have questions. I think we have microphones.
Should we turn our...
Questions? We have one here, over there. Yes. Dr. Stone.
Yeah, so I'm from Cedars-Sinai. Thanks to panelists for a very interesting discussion. I would ask Dr. Curry if, after hearing Dr. Ganzini show that most patients who were requesting this, the vast majority, do not have important symptoms as a motivation, if it makes sense to have a mandatory palliative care consult, because for patients at the end of life, that might seem burdensome, another hurdle for them to overcome if they're really trying to relieve their own suffering.
My microphone works. Okay, perfect. Just wanted to make sure. So thanks for asking that question. I think, the distinction, what I would say is that palliative medicine isn't just about physical suffering, that there's quite a lot of existential and spiritual suffering that at least the patients I've seen in my career come with, and that influences, and there's a complex interplay between the existential, spiritual, emotional experiences as well as their physical symptoms. And it's not to say that there aren't some patients who I've come up against a wall with even the very best palliation that we can offer. There are always going to be those patients who say, I am suffering too much and I would like to exercise this other option. But I don't think that's a reason to deny them the opportunity to engage with a palliative specialist, and I think that can make their quality of life better.
Go ahead.
So in our studies, we found that if a patient makes a request before they go in hospice referral is the most effective intervention for the patient to consider another alternative besides physician aid in dying. The second thing is, I think even if the patient chooses physician aid in dying, their quality of life will be better before they die. That they will, and many patients who want this choice are suspicious of hospice. They're suspicious of more care. They don't like the idea of nurses coming around and poking around in the refrigerator. And so that, but if they can be convinced that hospice will help them improve, have more control, and that they can accept as little or as much hospice as they want, I think the quality of their life is better. no matter what their ultimate decision is.
I just wanted to comment, looking back to the 1990s in Oregon, and I'm thinking of a colleague of Dr. Genzini's, Susan Toll, who ran the ethics center there and was also involved in palliative care. And she remarked that at that time she had great difficulty getting Oregon physicians to come in and learn about end-of-life care and the various ways in which particularly palliative care could be of benefit to their patients. But as soon as the death, is it called Death with Dignity in Oregon?
Yes.
Yeah, the Death with Dignity Act was passed in Oregon. She couldn't run enough seminars. They were just all oversubscribed. And her explanation from talking to the people signing up was that they had previously been able to tell their patients, if they raised it, reflecting what was their own discomfort. I can't talk to you about that. We just don't do that in medicine. You know, the patient would say, can't you help me die? Can't you give me something that I can take that would, no, we just can't. But once they couldn't say that anymore, they needed to understand palliative care. And I see, because I very much supported the policy that Dr. Puri described at USC, in part is another way of not just reaching the patient, but reaching the physician and having the physicians see the kinds of things that are available, because there's no way even an excellent physician like Dr. Puri is going to be able to get to every patient who needs it, not only those who are raising the prospect that they want physician aid in dying, or physician-assisted death. So it would seem to me that part of the rationale that one could say is it's part of helping the patient and educating the attendings about the things that they should be thinking of routinely.
I'm Shane Hughey, Environmental Health Sciences. I'm curious about Oregon and the potential application of, to California of this act to prisons.
What was that?
I'm not sure we heard the last word.
Prisoners. People who are in prison
Yes.
and who are incarcerated and who want to end their lives.
Might prisoner.
Yes, I am not aware of this occurring in prisons. So any healthcare system can, by policy, decide that they're not going to participate. For example, the Catholic hospitals contractually prevent their physicians from participating in the act. And I suspect that the prisons would also do that, even though our prisons have pretty good hospice units, because we do have many aging prisoners who die in prison. So, but I'm not aware of this occurring in prisons.
How about potentially in California, do you think?
I think that is a prison, as Dr. Genzini said, I think that's a prison management issue. And from what I have read, most people on the prison side would regard it as potentially a very disruptive thing in the prison setting. And there are a number of things which people can do that prisoners can't do. In the medical area, obviously, there are many things that prisoners can't do. In the medical area, since the since the early 70s, mid-70s, prisoners are not used in research unconnected with their illnesses or the conditions of incarceration. Now, the thought there is that prisoners are not free, they are less free to make decisions, and the decisions they make are more subject to control by the people who control their lives. And so we would have questions about their independence. So both from the prison management side and from the ability to make a unconstrained decision side, there could be reasons not to allow the application there.
Yeah, I think it's fair to say at this point that it's conjecture and would have a lot to do with whether the prison health system opts out, which I have not heard about. We have another question? Oops. Yeah.
She wanted to comment on the prison question. Is it discourse?
My thought is that the California Supreme Court in the Thor case said that a prisoner had the right to refuse treatment. And so it's hard to say how this would play out in the event of a challenge by a prisoner saying, I have the right to avail myself of this law. But it's possible that it could be decided that prisoners have the right to do that.
And Terry, I would agree with that as a possibility. The distinction, in my view, would arise from the basis of the decision to say that prisoners cannot be forced to undergo treatment which they object to as a general matter, and that isn't what they're sentenced to. In other words, they're not sentenced to accept treatment. That's not what is happening here. And so avoiding that intrusion seems to me not necessarily the same as the other. But as I said before, I can well imagine that this act is going to face people saying, I'm not covered by the act, and I should be, and I'm being deprived of a right. So having created this right, you have to distribute it to everyone who wants to use it. So I could imagine that prisoners might be one more category of that sort.
Okay, we have a lot of questions. Let me ask you to introduce yourself as you ask your question.
Oh, I'm Ann Kelly. I'm a lawyer, and I worked through the FSPH program over here a couple years ago. I just wanted to comment on the palliative care requirement question from the gentleman from Cedars. Just wanted to suggest that another good reason for having that requirement is to maintain public trust in both the law and in the institution that they're going to implement it. Because people are going to have that on their minds.
Thank you. Next question. We have a lot of hands up.
I'm Dr. Pawson. I'm from Ventura County Medical Center. I'm the director of palliative care there. And Dr. Curry, I'm curious as to when you wrote the policy for USC, what did you do about participation of residents and fellows in this act? I'm obviously licensed, non-interns, but since all their work's done under the direct or indirect supervision of their attendings, do you permit residents and fellows to be the attending physician and or the consulting physician?
Thanks, that's a great question. And there's two ways I'll answer it. One is by saying that no house staff, so no residents or fellows, can be the one to participate in the law, either as an attending or a consulting physician, because ultimately everything they do is supervised by their attending physician. So that decision was made because of that. That's kind of how the chain of command works. And there were attendings who felt that, if there's a disagreement, ultimately it is the attending who has to account for the decisions made in the patient care. That said, it is really one of my concerns, and the concerns of my colleagues, has been that it is very distressing to get those requests when you're a trainee. When I was a trainee a while ago, I would get these requests far before this law was passed, and just hearing someone say, will you help me end this, in its various ways that it's presented, is very distressing. It's distressing for nurses, it's distressing for social workers, it's distressing for everybody, regardless of whether someone's specifically asking for the End-of-Life Options Act. So one thing that I think needs to be augmented is just support for people who have gotten a request and are bothered by it or not sure how to navigate it. And the kind of informal policy is that if anything happens along those lines, that anyone's free to call our office, and myself and my social worker kind of help triage any of those calls. We haven't had a whole lot of them, but with informal conversations I've had with the residents and fellows who consult us, I know that this is on their mind, as is, the impact of stopping a certain kind of life-sustaining intervention, even before we're talking about the End of Life Option Act. So in general, I think we need to do a better job of addressing moral distress of our trainees, but certainly in this context.
I can add that at UCLA, both the attendings and the consulting physicians that have participated have made a point of involving a fellow or resident in every visit. And that's the point that they've made to me. They want that to be part of their education. Next question. How do you want to do this? You want to? Yeah.
Saul Angelat, I'm an attorney, but I am a graduate of the UCLA School of Public Health. I'm troubled about the position of the physician in this decision-making process. When we know death is imminent and it's going to be a few days or weeks, it's easy to exercise that judgment. When you go back 6 months, what is the degree of certainty that's going to allow the physician to make that decision? And I'm particularly concerned when I see the statistics that Sunita presented, where the physicians appear at this point, at least, many of them reluctant to make that decision. So what is going to be the standard there, particularly where the patient is requesting it and the physician doesn't really think that she is going to die within 6 months? What does that cause to what occurs to the physician-patient relationship and so on?
Dr. Genzini, can you comment whether prognostic estimates were a problem for the physicians?
So prognostic estimates depend on the disease process. For some like cancer, there's much better measures of prognosis. We know, Neil and I have a colleague, Nick Christakis, who did a study in patients, I think going into hospice, that showed that physicians overestimate life expectancy 5 times more than they underestimate it. So our errors are mostly that we overestimate life expectancy. But be that as may, there are about 1/3 of patients who receive lethal prescriptions in Oregon don't take them, and some outlive their 6-month life expectancy because of that uncertainty. And we know that patients that go into hospice, especially patients with neurodegenerative disease, get really good nursing care in hospice and get better and get discharged from hospice. I've had a couple of patients who've been repeatedly discharged from hospice. So, but even if there is uncertainty from the patients, as Dr. Camperon has said, maybe some of that's arbitrary. We tie it to the 6-month prognosis because we want to make sure everybody who makes this decision can access hospice at the same time. But from the patient's experience, it's not only about that they can see the end of their life, but they see a functional decline and a decline in their abilities to do the things that are meaningful for them. And they're experiencing that. And there could be uncertainty, but I think that's rare.
And it's important to remember that the 6-month magic number came in because of discussions among the actuaries at Medicare, who were trying to figure out what they could predict well enough to be able to say that this was not going to be a budget buster, that is to say that people given a new service, but not at the time, it was much more categorized. You couldn't get the curative service you were going to get, but how long would they live and what they had data about. And they were able to say, well, let's say 6 months. We can give a 6 month. And then it migrated out of what was an insurance decision into these statutes.
Are you saying the patient is just a statistic?
To the actuary, yes.
Next question.
Hi, I think your comments Hi, it's Richard Singer. I'm actually adjunct faculty at Hopkins in information sciences, and also quite religiously observant. So it's very interesting the distinction that you make it between active versus passive. I think it's really important. But I'd love to, and Julie, so two questions. One, I thought I knew what euthanasia was before I came in here tonight, and now I'm not really so sure. In the context of the whole spectrum you just described, it's a quick question. But broader, this whole notion of capacity, I was wondering if you'd comment on that more, because, I mean, who would be, quote unquote, depressed if they found out they've only got 6 months to live? And so it seemed like to be a very, in all seriousness, it seemed like a very slippery slope between, well, I'm feeling great and they're about life, and therefore I'm confident to make the decision, even though I'm going to be gone in 6 months, versus, the opposite. And so can someone, in Judaism, if you don't have a rabbi, well, one rabbi says, you go to another rabbi and ask their opinion. But quite seriously, according to law, can you shop docs and say, well, I need to find a doc, and maybe I need to find a psychiatrist who will do what I want them to do? So are there things like that? But in general, my question is really about this whole capacity, because it seems like once you've lost capacity, that's what people are really scared of.
I think it is true that a category of people who were concerned to have the law enacted were in the category who most feared that loss of control and mental ability. I'm going to defer on the depression issue to Dr. Ganzini, who is, after all, a psychiatrist, but just to comment that there is a difference between feeling sad because you've gotten very bad news and being depressed to the point that your decision-making capacity is seriously impaired. On the euthanasia issue, in U.S. law, as far as I'm familiar, and there are a lot of other lawyers here that can tell me, we didn't start off with a definition of euthanasia. We simply regarded homicide as the category, and there is criminal homicide, and there's justifiable homicide, and so forth. And the understanding was any intentional taking of a human life would be a homicide, and the term euthanasia was really being brought in from the outside by people who wanted to say there are categories that should be acceptable. It is a good death, euthanasia, and for a time in the 19-teens, 20s, 30s, there was a good deal of interest in that. It got a very bad reputation because the Nazis announced that their program was a euthanasia program, and so it was associated with all the other crimes against humanity and so forth. The Euthanasia Educational Council in the United States changed its name to Concern for Dying. First, Concern for Dying first, and then Choice in Dying thereafter. And so there isn't a legal definition really, but the example I gave is if I or anyone else under this law gave someone the pill, put it in their mouth, didn't give the prescription, didn't even put the bottle by the bedside, that's okay, as far as I would think, as far as I know, that's even explicitly covered. But if I put it in the mouth and held up the glass, and it was my hand holding the glass, even though it's their throat swallowing, I believe that would be regarded as I have taken their life and I'm not protected under this statute. And I'd be open to anybody telling me otherwise. And if I were doing it because I was doing something evil, people might say it's just outright first-degree murder. If I'm doing it in a loving way because I know this person wants that result and they've asked for it and they just physically can't get it, someone might say, well, that was a mercy killing. That was a euthanasia. And I know from talking to people in the AIDS community and at least one prosecutor in the 1980s that they knew that was going on at a time before there was any decent treatment and there were horrible deaths. And they just said, we're going to look at these circumstances, and if we think it was being done out of that kind of protective thing, we're just not going to bring these cases. And we didn't have prosecutions of people, and yet we know that those cases were even written up by some of the participants. They described helping people to die. And it was just felt, this is a horrible situation, and we're not changing the law, but we're just not regarding those as cases where, where we're going to prosecute. And what the prosecutor told me was, we couldn't get a conviction. It would be such a sympathetic situation, you know.
Do you want to comment on impaired judgment and whether there's doctor shopping?
Yes, so the issue with depression is in medicine, we distinguish, well, what we're really worried about is clinical depression or major depression, where people are sad, blue, depressed for most of the time over several weeks, a minimum of a couple of weeks. So it's really quite impactful. And that is different than being terminally ill, having bad days, feeling sad, feeling discouraged at times. About between 10 and 20% of people with a terminal illness will get major depression. But it's actually more interesting how many don't. And I remember doing one of my first studies in this area of patients with amyotrophic lateral sclerosis. This is a group of patients who are 30 times more likely in Oregon to choose physician-assisted death. And we used the Beck Hopelessness Scale. And one of the questions is, does tomorrow look better to you than today? And 80% of ALS patients said tomorrow looked better than today to them. So I think even in the face of terminal illness, people maintain ability to enjoy their life, to have pleasure, to feel hopeful, and that it's not necessary for people to get depression. Now, before I ever got into looking at physician aid in dying, and the reason I got into it is because I happened to be in the mid-90s doing studies of patients with major depression to see if treatment of depression made them more accepting of life-sustaining treatments, things like dialysis and mechanical ventilation. So these were just surveys. And what we found was major depression was only impactful if it was very severe and if it was so obviously associated with this very obvious distortions around their life or really severe apathy. So it was only a small number of cases where treatment of depression changed people's minds. Just one other thing about the California and the Oregon law, it doesn't exclude people with depression. It excludes people with depression impacting their judgment. And I have to tell you, as a psychiatrist, I'm pretty damn good at diagnosing depression. But I am not very good at all in these cases of figuring out whether it's affecting somebody's decision. I think that's quite difficult. And so what we end up doing is excluding everybody with depression because we really just have to assume it's impacting their decision.
And that was one of the major concerns at SC about physicians thinking about whether they would participate in this act, is feeling that they may not have the skills to know how much a comorbid mental health issue is influencing capacity. And the law doesn't mandate any involvement from a psychiatrist or a PhD in psychology. It's an optional consult, but it's not mandated.
And if I were to mandate a psychiatry consult versus a palliative care consult, that's an easy one. Make the palliative care required. Not psychiatry.
So we have about 5 minutes left. Let's see if we can ask a couple questions.
The question I want to ask Dr. Yancini is this: is there any difference? Can you identify? John Myers. I'm running 3 policies for hospitals right now in this area, and was a little bit responsible for USC, University Hospital. So the question that I have for you is there a difference between the California and Oregon laws such that under the California laws you would expect a change in the empirical results that you got? And if so, what's your take on why?
Right. So there are, I think, really quite minor differences between the law that I don't think are substantive. But I do think there's differences between California and Oregon. So
That's why you have a wall at your southern border.
so California is much more heterogeneous than Oregon is. And at the time the law passed, I think Oregon was, 94% Caucasian. And so I think that there's potential lack of generalizability of our data to the California experience. I think that's the major one. So I would really encourage more research to go on and just not assume that what we found will be the same.
Another question? Do you have a question here?
I'll ask a second question. Shane Huey, Environmental Health Sciences, School of Public Health. As a public health person and involved with training students, I want to ask the panel, how did the law in Oregon kind of affect any training of students coming through nursing, medicine, and public health? What do the California people think that should be done? Should this be done essentially through an ethics kind of focus or some other focus?
Well, to expand a little bit on what Dr. Capron said about Susan Toll, one of the other things that happened in Oregon when the law passed was that no hospital wanted to be on the front page of the Oregonian with a case of physician aid in dying where there was lack of access to palliative care. So every hospital, major hospital in Oregon has a palliative care team. And when you have a palliative care team and a palliative care fellowship, then I think you have an opportunity to offer a systematic approach, and also ethics. I don't want to leave ethics, oh gosh, I left ethics out. A systematic and comprehensive approach to training of medical students, residents, and fellows about end-of-life care. And we do have that in Oregon.
I think that's a really crucial question because, as Dr. Capron was saying, some of the concepts about the ethics of, for example, withholding a treatment or discontinuing a life-sustaining treatment, those are the types of things all the way along to the spectrum of when is someone eligible for hospice, what is hospice, what is palliative medicine, what's the End-of-Life Option Act. That whole spectrum of things has been it's ever more pressing to include, and from very early on. And I actually think that discussions about death and dying shouldn't just start in medical or nursing school, but should be actually a part of curriculums in colleges, like required curriculums, whether it's one class or part of a class. But it's a societal issue as well as one that's pertinent to those providing medical and nursing care. So, I think most medical schools have some semblance of an ethics curriculum, and as we grow in palliative care and have more people who actually practice it, I think the hope is to have more penetration into medical schools, nursing schools, residents, fellows, and even fellow attendings who are practicing physicians who may not know how to talk about some of the issues that we've covered today. So the education, I think, is societal, outside of the walls of a medical school or a medical institution, but it's also very much within those who are learning to provide care for people.
So this is a public health school forum. I'll ask one last question that is in that ilk. Health systems are now responsible for population health, for taking care of the sets of patients that they're responsible for. Certainly health systems can opt out, but those that don't, that are participating, do the systems have a responsibility to make sure that patients who request aid in dying have access to it?
Well, systems are made up of people, and the legislature, not just in this bill, but in previous bills, for example, there was a bill that began as something requiring physicians simply to describe all the end-of-life options, where the most extreme of the options was ceasing treatment. And that got watered down in the legislature so that if a physician were directly asked about them, they were supposed to answer. But the notion that you could have a law telling physicians that they should, with in appropriate circumstances as described with all these kinds of ends-of-life things, always raise and acquaint the patient with this, was defeated. And I have a sense that the law is as restricted as it is because most people think that as a matter of conscience, people should opt out. I think that when you put people together in systems, the system as a whole has that responsibility. And I know that there are systems where they are institutionally devoted to a particular point of view. And if that point of view is clear enough, and if patients actually have a choice of going to a different system and enrolling in a system that will give them more choices, then I think it may be reasonable to say even the system doesn't have to offer this. But I suspect that at least early on, this won't be something that you'll be thinking of when you sign up with XYZ insurer that has this or that panel of preferred physicians and hospitals, much less if you join a plan like Kaiser or something, where basically for most people who don't have very deep pockets, if it's not in your system, you're not going to get it. And so at that point, it seems to me we could say, system, figure out how you're going to do it. And I realize that would be very difficult for religiously affiliated systems. So it's not a final answer on my part, but I'm very sympathetic with people not having an opportunity to make the choice at the point where it really becomes then operative on them and they don't have a choice.
So in Oregon, there has been reticence to routinely let people know about the availability of physician-aid dying because of the worry that people will misconstrue that as saying, you know, this would, think about this as a cheaper option for the healthcare system. So that is not routinely done. And there was a couple of situations in which it was routinely done and it backfired quite considerably.
I think that a part of a system is to have accessibility and availability of all options for people. And I don't know that, you know, like Dr. Capron is saying, that advertising or making it known that the End of Life Option Act would be honored through a particular system is always going to work. But making sure that there's a better integrative, comprehensive approach for all options when someone is really sick or just got a bad diagnosis, including early palliative care. I think systems it's really incumbent on them to make that available, and I know that's the exception rather than the rule, unfortunately.
So we're not even a quarter of a year into the new, into this new act, and obviously this is a discussion that's just beginning. But I think we learned a lot from the insightful presentations of our panelists, and I'd like to thank them for coming to this evening. The next Paul Torrens Public Health Forum is October 26th, and thank you all for coming this evening.